now we are moving on to the next session, industrial session, and I'm inviting my co-chair, Dr. Adas Levy, to introduce the lecturers.
Okay. The next session is about home care technology from the perspective of the industry. And I think that following the lecture that we just heard, we understand that the industry went through a change in the last 2 years, and the services, the care models, the way we're working, and even new emerging technologies are now being implemented very fastly in healthcare. So we would like to hear the perspective of the industry, what has changed and how they see the future and the business model following the last 2 years. And I would like to ask Dr. רוני Tzabar, who is going to lead this discussion, to take the lead.
Yes, hello everybody. I'm not sure if it's good morning, good afternoon, good evening, or wherever you are. So happy to be here today. My name is Ron Tzabar. I'm a physician, and I'm the founder and chief medical officer of Tzabar Health, which is the largest and most comprehensive home hospital service in Israel. We have been around for about 17 years. And as of today, we take care of about 2,100 patients in any given point of time nationwide in Israel, which, by the way, puts us in either first or second place as far as hospital beds are concerned in the country. Just to show you what the future is going back to our patients' homes. And we take care of patients in 6 distinct home hospital wards. Internal medicine, acute rehabilitation, acute psychiatry, hospice care, chronic ventilated people, and chronic geriatric patients. And I'm very, very excited here because we have a fantastic panel for you today of leading technology companies all involved in the growing frontier of home-based medical care. We have a representative from Datos, which serves a platform for connecting IoT and helps with data management. We have representatives from 2 patient monitoring device companies presenting very different product concepts and business model, both EarlySense and BioBeat. And we have a representative of a company involved in patient team connectivity, prevention of loneliness and isolation, and managing large homebound patient populations, Uniper. So they've all very graciously agreed to join us today. And I just want to upfront thank very much my colleague Gadi Levy, which helped with this panel setting up. So thank you very much. And could we first have the representative of Datos, Uri?
Hey.
Hi. How you doing?
Good, thank you.
So Datos is a very, very exciting company today. And we want you to give us your perspective on, first of all, present your company, what you do, what's your platform, and if you can tell us on your view on the different markets between Israel and the US, and the way you think the transition of taking care of people at home with chronic conditions, how would that change with your tools?
Sure, and by the way, I'm happy or I'm honored to follow Avi's talk right before me, because I think it's a great transition. So just as about Datos is a software platform for remote care automation. We provide remote care programs mainly in the area of self-assessment and automation of remote care programs, maybe in HMOs in Israel or hospitals, but in the United States we focus on providers. The way that we look at the market is, if you look at the remote care, by the way, let me just, prior to that, I think Hadass mentioned home care. So just to make sure that we're aligned with the terminology, home care is where the care is being provided at home. So where nurses and doctors at home. Remote care is I'm providing the care remotely. Two separate things, not the same. And what we do is remote care and not home care. So we are not sending nurses and doctors and physicians. And the way that we look at the market is that, yes, you have on one spectrum the hospital at home, acute care at home. And on the other spectrum, you have wellness. In the middle, you have chronic conditions and transition of care from the hospital. So there are four main pillars of remote care activities. We are focusing, and we believe that the large numbers will be on the transition of care, or what we call episodic care. So for example, oncology, symptom management, balancing, titration, medication balancing for diabetes, everything that has a start and an end date. Those are going to be the large numbers. Hospital at home and wellness and chronic conditions, all of those. I think hospital at home, we will find out that there's no so much numbers over there in terms of the volume. And on chronic conditions and wellness, we're going to find that there is really big engagement challenge around, having patients on the programs for more than a month, 2 months. It's not easy to maintain that level of engagement.
That's your market analysis. And how does your product get involved with the market? How is this?
So we allow providers to design and deploy their own remote care programs. So as an example, in the Sheba Medical Center here in Israel, there are about 40 different programs of remote care. We provide a no-code environment, meaning that we're allowing the provider to basically design their own programs, may it be in breast cancer, pancreatic cancer, cardiac rehab. That's a successful program that got a reimbursement code here in Israel based on our platform, CHF, psychiatry, home hospitalization, a lot of different programs. And the idea is that there are building blocks for remote care programs, may it be vitals, surveys, virtual visits, content, messages, alerts. And with those building blocks, you basically can design any type of program out there. The main thing, and I think Avi actually mentioned that before, and we see that across the board, but mainly in the US more than in Israel, is the physician fatigue. Even if I'm going to present a positive ROI, if I need to add another nurse or another FTE, a full-time employee, that's not going to fly these days. We are in a severe shortage of medical staff. Hence the automation side of the platform. So you can design remote care programs with a lot of automation techniques that basically allows to reduce the heavy lifting and the tasks that are required from the medical staff on the other hand. Just another point.
Is it only automation as far as retrieving the information, as in a sense of pull, or also push instead of giving, like allowing patient information?
Exactly. So the automation is basically you as a provider, you decide what's the level of automation and when you would like to have a human intervention. So we always give the example of in oncology symptom management. Most of the times when you see symptoms, those are fine. You can continue with your drug and medication profile. In some cases, you probably will need an OTC, over-the-counter medication, or some recommendation on the content that you can read and understand better the situation. But in the 5%, 10% of cases where you actually need to see someone, or you need to go into the ER, basically then we bring it up to the medical staff, and we sidetrack from the automation pathway into a human interaction. But the idea is that you can design that. Like oncology symptom management will be different in different hospitals, and the idea is to align and design it according to the workflow in every specific organization. And that's the key here, because workflow and integration with the EMR and the integration of the data is the heavy lifting, is the most important task. Bringing the data, that's easy.
That's easy.
Converting the data into clinical utility, that's what the way that we call it. That's the hard stuff. And
agree.
every clinic is different in the sense of how they would like to consume the data and how they would like to convert it into an actual utility that they can do something with that.
And you managed to say all that without using the abbreviation PROMS, which is very, very...
PROMS, I can talk about it a lot of time. There
exactly.
is a move in the healthcare today from quantity to quality. And the idea about merging the objective data of the vitals with the subjective data of the surveys together to one holistic picture, I think that's the future, and that's what we excel in data.
Fantastic, Uri. With your permission, we'll move to BioBeat. And who do we have from BioBeat today?
Hi, that's Arik.
Hey, Arik. Great to see
Hi.
you.
Thank you for the invitation.
Yes, what an impressive backdrop you have behind you. So tell us a little bit about BioBeat, and how do you see your system fit with the current needs of gaps in various healthcare systems settings?
So BioBeat has completed the development and already commercialized remote patient monitoring platform that consists of several devices. The first device that I have on myself is a wrist monitor, and we also have a chest patch, I don't know if you see it here. And these small devices, which are wearable and wireless, provide continuous collection, measurement, and transmission of 13 different vital signs that include blood pressure, heart rate, saturation, respiratory rate, temperature, stroke volume, cardiac output. So quite a lot of cardiopulmonary vitals. We managed to receive already the full CE mark for the platform. And we are now step by step also heading towards completion of the FDA clearance. We already have clearance for the blood pressure, which is quite unique, non-invasive cuffless blood pressure, as well as the heart rate and saturation, and hopefully soon we will have some more of the vitals. And we started with a wrist device looking mainly at hospitals, but as time went on, especially during COVID, the need for single-use disposable devices that will allow remote monitoring became a real necessity. And actually things went quite fast. And this was a great opportunity for us. And then also at the same time, all the hospital at home programs developed, and not only in the US, by the way, also in other territories. And so I would like to say that I agree with Uri and say that it is important to have quality, but quantity can also help. So if you have the combination of both, and they are all medical grade and high quality, then you can really have the advantage of these objective insights that can help healthcare providers wherever they are and wherever the patient is now placed. So the same physician can see exactly what is happening with patients in the hospital, but also in patients at home. And the idea is really to help the healthcare providers. As was mentioned before, we see a lot of burnout. There is a lack of personnel. And don't get me wrong, we don't think that healthcare personnel should sit like zombies in front of hundreds of monitoring screens. The idea, and this is exactly what we are doing, we've integrated an early warning score into our system. So you have all of the vitals and you can look at each, but instead of doing that, you can get an alert notification if a patient is now showing early signs of deterioration. So putting an emphasizing prevention rather than response to deterioration, do it in advance.
So let me ask you, let me ask you this, Eric, because seeing from the eye of the provider, because our number one fear is being overflooded with terabytes of information, which
Exactly.
the overwhelming majority is we don't have anything to do with it. Not only that, but once the information is on our side, we're liable for it. So how do you help us not be, timid from these kind of devices?
So instead of looking all the time at all of the data points, you get the bottom line. You get the data, whether the patient is now probably going to deteriorate, and we prioritize that. So when you look at our dashboard, you can say that patient XYZ really need your attention right now, but the 200 others, you don't need to look at their vitals because we are taking care of that and we'll notify you if something is wrong. At the same time, all of the data is gathered and analyzed, and I can tell you already that we have some very exciting insights about how different patients, for example, congestive heart failure patients, oncology patients, patients with sepsis, how their vitals are looking when they are at home or in the hospital, and this really helps us to take the early warning score a few steps forward and provide you the more advanced alerts to give you the support and the, let's call it a situational awareness when you're taking care of so many patients.
Okay, so let me ask you that, and I'll ask the same question for Early Sense, because you're both pretty much in the same ballpark, in the sense that when there's the patient is connected, is there a phase of learning, getting to know that particular patient, or you're using the information that you have from all the other, tens of thousands of patients that you've monitored so far? Is, in a sense, is there like particular machine learning or AI that you're using for that particular patient, or there's no learning curve?
So the answer is both. I mean, the baseline is based on our previous experience, but as time goes by, we understand better the specific patient that is being monitored. And I can tell you that this is one of the ways we managed, for example, to show that by using this platform, we had a very interesting study on flu. We can tell 2 days before a patient feels anything that he's going to get the flu. Just an example. And you can take that and do the same with other diseases. And this is one of the more exciting things we're doing right now.
Yes, that's definitely will be the way companies or providers will be using this, only in the sense that it will be added value in sense of where is this patient going and not what's happening right now. Right now usually doesn't help us. One last question about your business model of using the devices which are physically connected to the patient as opposed to Early Sense. How is your feeling with patients and family members as far as adherence to the different devices? Is the patch sticking on? Does it fall off? How do you know when it falls off? Is there attrition because of patients not using it because it's too cumbersome? What's your experience with wearable devices?
Great question. So from our experience, if we're talking about a relatively short-term monitoring, the patch is perfect. It doesn't interfere. Patients show high compliance. I can tell you that whenever a person is being monitored with that, they don't want to hear anymore about the inflating cuff. For them now, there is a new world. They don't need to suffer from the cuff. They are happy with the device. When we are moving forward to longer periods of monitoring, when talking about 3 weeks, a month, and so on, the preference is to have the wrist device instead of having patches for a too long period. So this is one of the insights we have. The devices themselves are they automatically collect all the vitals. So the patient doesn't have to do a thing. That's the whole idea behind that. So they won't have to do anything. They just stick it to themselves or put the wrist device, and it's not really cumbersome. And that's it. From that moment on, they are being automatically monitored. The data is transmitted to any defined repository. It could be an EMR or a standalone system. So there is a lot of flexibility.
Are you dependent on the patient's home's internet system, or do you provide them with an independent internet connection?
So there are a lot of, again, there are a lot of possibilities. It could be using their own cellular phones. It could be through a gateway that is deployed to their homes. Really depends on the specific use case. But we have the answers for that.
Okay, thank you very much, Ike. And we'll come back to you and Uri as well. Representative from Early Sense.
Hi, how are you?
Hey, hi, Guy. Great to see you. Thank you for joining us today.
Well. Good to see everyone.
So tell us a little bit about Early Sense. You're, I think, the company with the most mileage on the road here. You've been around for a long time.
So the past 16 years, I think, we've been focusing on creating a new market segment. Actually, we have a sensor that's under the mattress that continuously and non-invasively, without any patient compliance, it's an automatic compliance, it's under the mattress and it's collecting the vital signs and more advanced features such as early detection of changes in patient condition and also full sleep monitoring that gives you a full picture of the patient. And by the way, answering your previous patient question, so the AI and machine learning are being based both on large population. We've been collecting data from many different types of patients, many different types of facilities, and we know how your normalized rhythm will behave in a comparison to your age, to your condition, and so on, and therefore we're able both to normalize you against the population and against yourself. So those are the things that allows us to do the early detection of changes. And we've been doing the past 16 years until February this year that we sold the business unit of the acute care, which is hospitals, to the largest bed company in the United States, Hiram Company. They are now selling older beds with Early Sense technology activated. It means that one of every second bed in the US market today is using Early Sense technology.
It's incredible.
Yeah, so it's a great joy to see like this very long journey allowed us to really create a monitoring wherever there was no monitoring. The general wards was never monitored, and today every patient that lies on the bed has his vital signs monitored, and it's being like a new standard of care. And probably 10 years of now, no one even will remember the time that you went to a med-surg department and didn't have any kind of monitoring. In the past 2 years, we've been pivoting towards the home. Part of the things that led us to do that is the COVID pandemic, and we understood that the same technology that we developed in the past 16 years is very much suitable to deal with the challenges at home, mainly the compliance challenges and mainly the challenges to keep patients on a longitudinal basis using technology without having to charge the devices, without having to wear them and so on. And we're there today, and we're be happy to help creating this market segment even more fruitful than it is in the past few years.
Okay, which markets are you involved today, aside from the US market?
So today we're mainly finishing our our first generation product, and we have been selling under the EUA, Emergency Use Authorization in the US. We're still under the FDA submission that we submitted. We probably will have the system cleared by probably by the next quarter next year, maybe even we'll launch it in the third quarter of 2022. And in parallel, we're working with other markets, but still not not active, not too active. We're just doing the restart and full pivoting of this technology towards home. So it takes some time to reach the right.
So that leads me to the next question of, because of your perspective for so many years being in the market, how have you seen the market change?
Yeah, so like a few years ago, many of the things that we had to deal with, many of the challenges, was even to explain why it's needed to be early in the picture, to monitor a patient when he's not like complaining and so on. And I think that has been changed in the past few years. And the major change has been in the past 2 years that everyone around us is using technology, and we couldn't pass through this pandemic without having remote care and without having technology engage in our day-to-day life. People have been working for the past 2 years, making their office everywhere, and you know, having a new situation, and that really helps to open new segments that was very slow in the like 10 years ago or 5 years ago. We had like few options to go to the home market, and we didn't go there because it wasn't very mature at the time. So I think it's,
I agree that with the pandemic, the one thing the pandemic did is take out from the equation the question why. Nobody's asking why anymore. They're asking how, what is it exactly, who's going to pay for it, but nobody's asking why anymore. That's done. All right, thank you very much. We'll come back to you, Guy. And who is our representative from Uniper? Do we have a representative for Uniper? Okay. So Uri, back to you from Datos or Datos. How do you pronounce it in English?
It's from data. So the way we pronounce data. Data.
Okay. Now the question is, I think one of the from technology companies' point of view are actually the need.
You're broken up a little bit.
Okay. I'll say it again. I think one of the biggest advantages that you can provide for companies who are the actual hands-on providers is the dual effect, positive effect of, on the one side, the patient will feel that he's being touched a lot more times, and on the other side, the staff is actually touching him less times. So like a dual win-win situation. So how do you actually, you know, we can talk about bots, we can talk about, you know, again, AI. How do you actually do it? I mean, how do you learn that process? How do you allow it to change? What's your process in that?
So first, I think it's important that we recognize that here in Israel it's plus, and in the US it's around only for 20% of the providers it's a plus, because all the fee-for-service, that's not a plus. And all the CPT codes that you have in the US right now for remote care, and in 2022, we just heard it from Professor Avi, are going down. So fee-for-service, nobody is going to basically enjoy that. They would like to touch the patient as much as possible, because every touch is basically a code. On the capitative model, on the value-based model,
unless they're being paid for global
capitative
service. Exactly.
Yeah.
Exactly.
Yeah. But the capitative and value-based is pretty much the same. It's the idea in the way that our approach is basically to understand the medical guidelines. We are now, just today, we have a process around UTI, and it's a very common phenomenon. And the idea is that, again, to understand when do I need to see a physician? When do I need to see human? And every other cases, and there are many of them, we can basically automate and provide bots and understand automatic interaction with the patient, not only in the sense of sending content, but okay, do you have fever? And if you have fever, what are the other symptoms? Okay, now I need you to measure blood pressure. That entire protocol can be automated, and only then to make a decision, a triage the decision, whether I need to see a physician or not. So in Israel,
so that's already automated, or not yet?
Yes,
that's already automated. Okay.
Not only that it's automated, you can decide. This is on UTI, just as an example, but on any medical condition. That's the whole concept of the product, that you can basically design automated care pathways and decide when to get a physician to the human interface. And to be honest, in Israel, there is no question. Like everybody can see, like it's a better care. Great, let's do that because it is a better care. I'm touching the patient. I'm providing the patient much more care, and I'm also saving time for the clinicians. In the US, as I mentioned, you have the interaction between fee-for-service and value-based. And again, I know that there are CPT codes, but no one is actually really, there's no big large adoptions of those CPT codes in the US. The main providers that embrace remote care are the ones that their percentage of value-based revenues are the highest.
Okay, so that's a barrier to entry for products like you.
We focus on the value-based, yes. We do have the, again, we do have the CPT codes and the reimbursement, and we have the integration with the revenue cycle management and all of that, but that's not the large adoption of remote care or remote patient monitoring. The large adoption will be done by the value-based organizations. And again, this is not a clear cut. Every organization have a certain percentage of value-based and a certain percentage of fee-for-service. The idea is, where do you cut the line from a revenue perspective? And what we learned, by the way, this is something that I think is really important. We learned that when you cross the 35% of revenue from the value base, then the physicians, the clinician state of mind move from a state of mind of fee-for-service to the state of mind of a value base.
So that there's a threshold of 35% that they need to say, okay, this is a real business, I'm going to shift.
I'm going to say in the entire state of mind, I'm going to provide you care because I would like to provide you better care and don't want you to get back to the hospital, versus, no, I need to do more interactions, and every interaction I'm getting money, so this is the different state of mind.
Have you had any experience in large European markets where the paying system is different?
To be honest, no.
Okay, fair enough. Because I think it's really important when we talk about products with the US, there's always the hazard of being biased from the payment side of things, and sometimes not from the actual clinical protocol benefit of the patient side of things. So it's important. Anyway, great. We'll come back to you soon. Arik, are you with us?
Yeah.
Great. So I'm eager to hear how has BioBeat changed with time. You've been around for a few years now. What were your main lessons that you've learned that maybe other companies or other providers can benefit from your wisdom?
Well, first of all, regulation, of course, is very important, because when you have it with your products, then it really changes the way medical centers and providers are looking at you. I mean, it's obvious, but I mean, it was so strong and important on our way forward. This really allowed us to deploy it quite heavily during the COVID. I think we are facing a very, very conservative environment, and it's very difficult for physicians with a lot of experience to change the way they think. But I must tell you that we see the change. We see the change. I mean, they have to adapt and adjust to the changing world. I can tell you that you mentioned the different CPT codes. So just recently, they've added some CPT codes, not only for physicians, but also for paramedical personnel, physician assistants and nurses and so on. So we actually do think that it will change and increase. However, when we are speaking with hospitals, usually they ask us about the best CPT codes for remote patient monitoring, because for them, it's still the beginning. And even though there are a lot of programs funded by the US government, and there are a lot of hospitals taking part in these initiatives, it's still the beginning. I think that the fact that we have a flexible platform, that it's quite easy to deploy, this is one of the things that really the different providers like, different healthcare providers. And and once they are using it, they see the benefit. They understand how it can help them to reduce the burden. They don't have to collect vitals anymore. Everything is automated and directly transmitted to the MR and so on. So it really changes quite dramatically their workflow and gives them more time either to speak with the patients, be more aware of the medications and so on. So again, a shift in the way they were doing things until now.
Hopefully you're right. I mean, we've seen anything in the medical world where you know, you vacate time for physicians to sort of do other things. Usually it doesn't translate into talking more to the patients. But hopefully you're right. Have you looked into markets that are outside the US? And I'm thinking a product like yours might be good in third world countries and developing countries. Is it something that you're looking at?
So actually the fastest deployment and transmission of data took place in Congo a few months ago. It was really quite amazing. Everything went so smooth and fast. We also have experience in Nigeria, experience in Thailand, and there are some other markets. Actually, you know, I was speaking about the FDA and how we are moving slowly with the FDA. Except for the US, the platform is basically cleared for all of the vitals everywhere else, in Canada and Australia and so on. So it's kind of funny, you know, because we are always focusing on the US, and we are investing a lot of efforts there, but basically everywhere else, everyone is very open for the system and they're using it. So so definitely.
So let me ask you. Let's take a hypothetical scenario of a doctor sitting in Canada in some tertiary center, and he's taking care of people in the Yukon or in the Northern Territories. And so, are the devices? Can you transfer them from patient to patient, and sort of for a few days have this patient transmit and then another patient transmit, like for like a very remote rural clinic? Can it have just a few devices and turn, you know, switching between different patients?
So the answer is yes, but again, you have to choose whether you prefer to have the single-use disposable patch that works for a few days, or you prefer to have the wrist device, and then, as you mentioned, you can pass it from person to person. There are always pros and cons for transferring a device from person to person in terms of infection transmission and so on.
Of course.
But yes, it is possible. And I can tell you that just a few weeks ago, you know, there was the Medica fair in Germany, conference, and you know, I was sitting in Israel talking with one of our distributors in Sweden, and we were looking at the vitals of our representatives in Germany at the same time. So this shows you how it breaks geography and brings everyone, you know, to close proximity, and you can monitor basically anyone everywhere. So this is a great advantage.
Excellent. Thank you, Arik. Hopefully we'll have more time to talk to you. Guy, are you with us?
Yes.
I know there are companies looking at the possibility of passive monitoring under the mattress and under armchairs and stuff like that, which are spread more across the patient's body and not just centered at one area. And also there are companies that are looking at passive monitoring from smart cameras around the house, which then have the ability to monitor the patient everywhere around the house and not just when he's in his bed environment. Are you guys looking at that? Is that a challenge for you? How are you looking at that?
Well, let's start by showing the uniqueness of what we're doing. So first of all, whenever you want to get a picture, a solid picture of a patient, of someone that's on the bed, the best time is during the time that he's relaxed. It's the most predictable time in the day, actually. You don't have any annoying calls, you don't have any, you know, interactions with people that you like or, you know, or dislike and so on. So from one end, I think that the technology of having that under the mattress even though if you have two patients in bed, you can still collect the right patient, the one above the sensor. So that's one of the changes we did to this technology in the past 2 years. It can collect a single patient in a dual bed. And you have a clean picture. And then also you use all the data that EarlySense has collected throughout the years from hospitals, from post-acute care, and so on. There are more than 1 million patients that used our system and trained our models. So we have like a big advantage that has lots of reference data and lots of models actually, that actually have proved that they work and so on. Most new technologies still have to go through those phases and to collect enough data and so on. Most technologies are more focused in spot checking or testing throughout an episode of the day, and the data is not as predictable and clean as the data that you can collect under the mattress. One more thing that I think that makes EarlySense unique is the capability of monitoring accurately the respiration, and the respiration is a very important parameter. It helps us both to follow up on on patient with respiratory issues, but it can also make our sleep analysis more accurate when you have more than just motions and heart and so heart rate and so on. So I think that we still have advantage that's unique. We still have things that other solutions don't have yet, and we actually use the mileage that we have in order to come into this market with much more prepared product and much more prepared solution.
I must admit that as a hands-on physician, who has a lot of mileage in visiting patients in their own homes, I think it would be worth looking at the patient's out-of-bed environment as well, because the width of steps, the amount of time he opens the fridge, the amount of time he goes to the toilet, did he not open the front door, did he not answer the phone? All these things, these social parameters also have an input, but I agree with you. I mean, most of the patients are bedbound a lot of the times, definitely the ones that we're looking into the future of.
Yeah, and I totally agree with you. And we do have the APIs based on the cloud that we have that's easy to integrate with other technologies and other sensors that we can just connect to and so on. And that's something that we feel that we'll have more and more in the future. That's for sure.
Arik, you want to say something?
I would like to comment.
Yes, sorry. Yes.
That's good. And data and EarlySense also with BioBit, we provide agnostic integration to different devices. And we worked in the past with BioBit on heart failure, on clinical study. Also with EarlySense, we are now discussing the collaboration, and through Datos, we will be able to together to combine the EarlySense sophisticated data with Activity Watch and other medical devices. The point is that I think there's no right or wrong, and for every medical condition, there should be a lot of options around devices, and I think that mainly in the area of monitoring on behalf of hospitals, on providers, there should be the flexibility to provide different type of devices. So even BioBit, that they have the most sophisticated blood pressure watch, in some cases you might just manual entry will do of your regular blood pressure cuff, and in some cases you do need that top-notch BioBit, and the idea to be flexible around it and to provide the best hard rate to the remote care program. I think this is important, and I think this is where we're going to see the future. That there's going to be a lot of different devices, and the idea is how to marry the right device to the right remote care program.
Excellent, good input. Very last question. Since I think the biggest tsunami heading our way, at least in the developed countries, is patients handling dementia. That's where it's going. that's the number one population or illness coming our way. And as of today, Datos needs patients' cooperation with putting in information. Doesn't need it all. So it's completely passive.
Again, it depends on the way that you design the program.
Okay.
So a program can be completely passive if we will integrate with a device like EarlySense. But I think on the dementia side and more on the VR specific. Yes, passive is really important, but also I think best of breed solutions that knows how to understand the pattern and the behavior of the patient itself, and to learn from experience is really important. And there is the dementia solution on one hand, and there is also the psychiatry and psychology solution on the other hand. That you've seen a very large spike during the pandemic. You can see the case of Talkspace, what we all see in the stock market. But I think that right now we face a different type of challenge. If the remote care was in hype during the pandemic, now the lack of resources and the ability to basically to, you know, there was just an article in the US about around 6,000 nurses shortage. So the ability today to
6,000, I would assume it'd be more like in the 60,000 at least, but yes.
I'm sorry, 60,000. Yes, you're right.
Yes.
You're right.
Yes.
So basically, what I'm saying is the idea is to provide automatic solutions that will not require more medical staff. I think that's going to be the key in the near future.
Excellent. So we're literally on the on our fumes as far as times is concerned. So the stage is open. And any of you three want to say last words, then I'm more than happy to. You're welcome to. Arik?
Yes, please. So I'll just say that definitely the near future is exciting. I think that as time goes by, we understand more and more about the capabilities and the potential in these devices. I'm not talking only, of course, about the BioBit, but we see more opportunities. I can tell you that we are quite surprised that at least a third of our customers are actually large pharma companies. We didn't expect that to happen, but they are using our devices to shorten the timeline of their clinical studies. And since, again, the regulation is with us, the data is valid and accepted by the regulators. So this helps them to either repurpose old drugs or to develop new drugs. And even though questionnaires are important, we do see that objective parameters have their value, and it's very important when you really want to understand side effects and things like that. So just an example of something that we didn't expect to have, and now it has a very large portion of what we are doing. And definitely, I think that more and more healthcare providers will understand the advantages and the merit of using remote patient monitoring platforms, providing them with high quality and quantity of data that will help them, get to the right decisions about their patients.
Thank you, Arik. Guy, last comments?
I believe that we're getting into the era that people can really go to hospital only when they need to go to hospital. I believe that it will take some time, but I think that we're heading there with large steps, and hopefully we'll have that when we're old or sick and need that. So thank you for everyone.
Wonderful conclusion. I feel obligated to present at least the fourth party that was supposed to be here, Unipair, and because their technology approach is about a different aspect that we haven't spoken about, and I think is just as important as the medical parameters, is all about the psychological welfare and loneliness prevention of people who are at home. And their platform is based on the patient's regular television. They don't need to install any specific devices. They use their regular television as a connectivity device between the patient, their family, and the team, the medical team, and as a platform for simulating as though he was in an old people's home or in a facility, in the sense that he can have the recreational facilities, the group meetings, the storytelling, the physiotherapy, the group physiotherapy, and so the get together. So I think it's a wonderful platform as well, and we mustn't put aside technology for preventing loneliness and social and mental well-being is just as important. I want to thank everybody for listening, for participating. It's definitely exciting. This is the future of healthcare, going back to our patients' homes. And even though medicine it's always been about providers, about patients, and about medicine, it's definitely not the same medicine as it was 200 years ago. We're not the same physicians, and our patients are definitely not the same patients. So it's a huge challenge, and I'm happy all of you are involved, and thank you very much for your time.